and play the video, please.
Dear Chairman and dear my friends in India, I want to thank the organizing committee for inviting me to attend the AIOS 2021. And I'm Anguo Wang from Taipei, and today I'm going to talk about the endoscopic plication of inferior rectus muscle for traumatic IR injury. First, we would like to look at the epidemiology, and this is a study conducted in 2014. They have recruited 36 patients, and as you can see that sharp object or metal hook injury is the most common cause, and sinus surgery would be the second common cause for the extraocular muscle rupture. And the most commonly involved rectus muscle would be the medial rectus muscle, and the inferior rectus muscle was the second most commonly involved rectus muscle. Preoperative examination was very important, and a slit lamp can help us to look for the free distal end, and the range of motion is important, and also the force suction test may help us to detect the severity and the field of restriction, and the force generation test may help us to locate the proximal end during local anesthesia, but it may cause the muscle to retract further back. Image study may help us to check the rupture muscle condition. As you can see that CT scan may help clearly demonstrate the rupture site along the rectus muscle. Treatment for the inferior rectus muscle rupture have several options. The end-to-end anastomosis is the first choice, but the key point is how to recover the proximal end of the ruptured muscle. We can do the microscopic exploration and also use the force generation test and the IO capsulofascial sling to help us to locate the proximal end. If we couldn't locate the muscle proximal end, then we will have to do the inverse knot procedure to transpose the medial rectus and the lateral rectus muscle downward to the IR insertion site. On the other hand, the interior transposition of inferior oblique muscle may help as well. Let's look at our case. He is a 40-year-old male patient, and he had a syncope and fell down with face contusion. He visited ER in another hospital and received the primary repair of the conjunctival laceration in the right eye. During the operation, rupture of inferior rectus muscle was found, and the oral steroid was given. 5 days later, he came to our clinic, and as you can see that the vision was good, and he had a swollen eyelid and also chemosis in inferior conjunctiva region. Prism cover test show a 25 to 30% diopter of right hypertropia with severe limitation of infraduction. Impression was inferior rectus muscle rupture in the right eye, and oral steroid was given. 1 week later, he came back with right hypertropia of 18 prism diopters, and there is still moderate limitation of infraduction in the right eye. The patient, the image study showed there's tissue edema over the inferior rectus muscle region, and also you can see that the inferior rectus muscle seems to be intact over the sagittal view here. So we form a surgical plan that we will try to do the microscopic exploration of conjunctival wound first, and if we could recover the proximal end, then we'll do the primary repair of the inferior rectus muscle. If we couldn't find the proximal end by the conjunctival approach, then we will call our ENT colleagues, and they will help us to do the endoscopic exploration of the inferior orbit through the maxillary sinus and retrieve the proximal end of the inferior rectus muscle, and we will do the end-to-end anastomosis if possible. However, if both approach we can find the proximal end, then we will have to go on for the inverse knot procedures. Here is the surgical transconjunctival approach, and as you can see that the force duction test was negative, and then we make 2 linear radial cuts over the inferior conjunctival region, and then we will incise over the perilimbo conjunctiva, and also dissect carefully through this wound. And as you can see that there's a lot of bleeding because this will be the second surgery of these regions. And you can see there is soft tissue overlying the insertion regions over there. And that would be very important if you use this microscopic exploration, that we should do the dissection meticulously and careful not to do too much opto exploration that will cause that will help, that won't be able to locate the proximal end. And so after the dissection, you can see the residual tissue is not too much left over there. We hook this tissue, and after cleaning up the bleeding, you can see that the residual muscle tissue is very thin and very small, and also we cannot find the opening of the posterior tenon, and we could not locate the proximal end of the muscle. So we called our ENT doctors to help us, and he will first try to get into the inferior orbit to locate the inferior rectus muscle. And first he will need to get into the maxillary sinus, and he using the punch to make an opening over the medial wall of the maxillary sinus. And as you can see that he has already entered into the maxillary sinus, and he is trying to remove the mucosa overlying the maxillary sinus. And here is the inferior wall, orbital wall, and he was removing the mucosa lining, and here now he is using a knife to try to cut through the inferior orbital wall. And after several tries, he take out the piece of the bony tissue over the inferior orbit region and make an opening of the inferior orbit. Now you are seeing a reddish longitudinal tissues, and we believe that this will be the inferior rectus muscle, and so he's using a surgical clamp to pulling this rectus muscle out. Since it should be already ruptured, so we should be able to pull out this inferior rectus muscle from this opening. However, you can see that it was very difficult to remove this inferior rectus muscle, so we suggest him to change into a muscle hook. And using this muscle hook, it should be much more easier to remove this inferior rectus muscle from this opening. However, it seems we were unable to take out this inferior rectus muscle. So we think that maybe this inferior rectus muscle has ruptured and retracted through the posterior tenon hole, and it has already reattached to the eyeball again, so we won't be able to pull out the muscle. So we are trying to verify if this is the inferior rectus muscle by checking the eye position. We will pull the eyeball from outside to upward and to see if the muscle will retract it back. Now you can see that he is trying to, we move the eyeball from outside, and the ENT doctor will track the inferior rectus from inside. And when he was retracting the eyeball now from the inside, you can see the eyeball were rotating downward from outside. And now I will pull the eyeball upward again, and then you can see there's muscle retracting back. So that's really the inferior rectus muscle. And then they asked me, what can we do now, since the inferior rectus muscle still adhere to the eyeball? So I think I suggest that since the inferior rectus muscle is still adhered to the eyeball, we can do the plication of the muscle, inferior rectus muscle, so that the function will be improving and strengthening up by the plication procedure. And so I suggest them to use the muscle hook here and make 2 stitch over the plicated inferior rectus muscle. Then the inferior rectus muscle will be shortened and its function will be strengthening up. And as you can see that our ENT doctor was very skillful, and they make 2 stitches over the plicated muscle, and then finally they will do the endoscopic plication of this inferior rectus muscle. Okay, it's done. So the patient came back very happily that he can ride the motorcycle and by himself. And as you can see, that at primary position, the eyeball was orthophoric, and the infraduction improved a little bit, but still have a mild limitation in downward gaze. And however, he had a primary position orthophoric. And we looked back the literature and we found that lost medial rectus has been retrieved by endoscopic approach in year 2000 and year 2015. And also in 2019, medial rectus has been re-anastomosis by endoscopic approach. So in summary, we believe this will be the first report of a transmaxillary endoscopic exploration of the inferior rectus muscle surgery. And this is also the first report of endoscopic plication surgery for the rectus muscle. And the patients do the whole course smoothly and had a very satisfying results post-operatively. Thank you for your attention.